Gaurav, and Gaurav is going to be talking about the use of money blades in his femto cases.
Thanks, Kamal, and fantastic talk, Natasha. I really enjoyed your lecture, and especially the summing up slide as well. And Kamal, you've actually made my job easy because your talk on the blades was so good. I have actually cut short my talk in few places just to restrict it to what I'm speaking on. So I'll just share my screen. In fact, Kamal's talk was fantastic. He covered all the small points, and I could, actually remove a few of the things that I didn't want to speak on anymore. So uh, I'll be sharing my experiences with making incisions with the keratomes versus the femtosecond laser. And so how would you like your incisions? Now, if you do topical anesthesia, phaco or flax, you would probably be doing clear corneal incisions. So I'm going to restrict myself because, over the period of last 20, 25 years, I evolved from making SICS incisions with, crescent plates and, onto limbal incisions and then going on to clear corneal incisions a long time back and then evolving with the corneal incisions as well. So ideally, good incisions would be easy to make with minimum resistance. Precise, it should be a square incision, well placed, non-leaky, well sealing. Now, problems with bad incisions, I cut short these slides because Kamal spoke so well about all the possible complications you can have. It can lead to a complicated surgery, and very rightly said by Dr. Himanshu that, residents who are learning or phaco beginners, they actually are the ones who probably need the best, keratomes because, if they have a compromised incision, their surgeries are going to get more and more complicated. You could have leaky wounds with, shallow chambers and surges and everything. And if you had a tight wound, you would get wound burns. So, having the right keratome of the right size, giving you a predictable incision every time is so critical. Then, if you had poor keratomes, and I've seen that happen. I've gone through post-graduation. I've gone through the situations where, for purposes of economy, we would reuse our blades after autoclaving them. So I think over the time, I realized that no compromises on, my keratomes, even if you end up spending a little extra money and charging more from your patients a little bit, you really need good keratomes for yourself. So no irregular incisions, sudden entries, and I'll show you a couple of videos of what can happen with that. Now, most importantly, in today's world where we are aiming for perfection, astigmatism, either inducing astigmatism with your incision or having a bad incision which you need to suture, can both compromise your surgery. Decimate steers, Kamal spoke so well, and they can be a big problem with blunt instruments or poor quality keratomes. And of course, if you have a very bad incision, you could have inflammation, you could have endophthalmitis. So I started using in the late 90s when I was doing SICS, I really started enjoying the Alcon knives for making my corneal, my scleral tunnels. The Crescent, I remember, used to be of extremely good quality, but then that time we had no choice. Then in the early 2000s, we moved on. We started, playing with the diamond and sapphire, looking at some of my top surgeon colleagues who were using these blades. And soon I realized that, they were not really as good as they, looked on these videos that we see. And we moved on to other blades like the sharp points and the BD I used for many years. Dealt with a lot of Indian blades, which are pretty good actually. But I think the blades that we currently use are in a class of their own. Moved on from all these blades. 2015 or somewhere around that time, we started doing femto-assisted surgery and started using the money knives as well. Maybe a year later after that. So here I wanted to share some instances of which will tell you what all can happen with a poor blade. Now look at this. This was a post-vitrectomized silicone oil. Now just see, it looks very innocuous, but see what it's done. Sudden entry, and I have an intumescent cataract which is now punctured here. So it was in a flash of a moment, and then it was gone. And you now have a situation where you could have possibly a flag sign, and you could have complications there. Now let me take you to another small situation where here this is a patient, I think, where we are planning to do an ICL. See how easily the side port blades go. It's a nice money blade which is being used. And for the main port, for ICLs, we actually use a 2.8, a 3 mm incision, which probably I think money was not making. For some reason, we were using something else. A disposable Indian blade was being used. And just watch what happens when we make the main incision, because you need a slightly larger incision for the main port for ICL, whereas for cataract I use a 2.2 money double bevel plate. Now here we are going to make the main incision, and just watch as I try to make it. It's probably not of that good quality, and as I try to make that, just see that it's become a little difficult and it goes suddenly. Now just imagine if I was to go and puncture the anterior capsule of this patient where I'm planning an ICL. So it's so critical to have a good quality keratome for all your patients, whether be it cataract, be it ICL. You would probably want to do the best. Now, looking at some problems that we faced with the Femto, like Femto, I love the femtosecond laser, and I really enjoy using it for all my complex cases. So nothing against the Femto. I really use it as my first choice surgery for so many situations. Yet when it comes to corneal incisions, I think over the years what I've learned is that if I want a predictable, good quality incision, I've actually in the last 2 3 years stopped making my incisions, because for many reasons, it saves a lot of time, because the planning and the placement of the incisions on the femtosecond laser, then also trying to open those incisions, many times they'll open effortlessly. And then there will be other times when you're doing a VIP patient, you're doing a trifocal lens, trifocal toric, and then you suddenly have an incision which didn't open correctly. And just watch this video as it proceeds. Let me take you to the point where the incision is being planned. I'm sorry about that. Now here we are planning the incision, and we've gone ahead and gone ahead with the incision. Look at the incision over here. The planning is done. Now, as we execute it, I'm going through with the lens fragmentation. Just watch the incision over here. Can you watch this? Can you see that there is this skip area over here? It made it all the way from here till here, skip area. So sometimes, even if you identify the limbus right, the femtosecond laser, because it's OCT guided, may make the incision, either too anterior or too posterior. And then you may have situations even with the side ports. So look at this, what happened with this incision. My incision came right onto the conjunctiva over here because the laser falsely identified the limbus. I have to abort that incision and go in with a new incision. And you can see that making this incision is so much simpler and straightforward. So going on, there was another situation here where we made a femto incision, and I'm going to try and open that. You can see that sometimes these incisions will not open as you would like them to. And even though I've got into the correct plane, you can of course go wrong with the planes and so many other things. And then, you can sometimes have to actually complete your incision. And these are the cases where you may actually have a poor entry wound. Now look at this. I'm trying to close this incision and I'm sealing this. Now you can see the gap here. Can you see this gap over here? This incision is not great. It's going to leak, and it's probably going to induce astigmatism as well. And I hate incisions like this. This is the reason why, even if you get like one or two incisions like this, just see it's leaking. I'm not happy about it. And I'm trying to seal that again. And maybe in the end I'll manage, but if you don't, then you have to do something about it. Another small situation where I have a good looking incision and I think I'm happy about it, I'm going to do well, but I'm now dissecting the vertical part of the incision, the first plane, and then I get into the second plane. Bit of a challenge sometimes. Now just watch what I did. Just go back and see, when I entered that plane, I pushed the descendants here actually. So sometimes that inner lip will not be so perfect, and as you try to dissect the plane and get in there, you may produce a small descendants attachment there as well. And then you want to actually open up the incision completely on both sides. So after years of doing this, I realized that my incisions with these keratomes that I currently use, the money ones, that they are so much more predictable and good in their construction and anatomy. I decided that I don't need to make incisions. Look at what happens now. I've injected the lens and continuously continues to leak this wound over here. Exactly same patient where you can realize that my wound is main port is leaky, and I'm going to have a trouble trying to get that lens in and then trying to seal it. And here, as I seal it, you can see that I have to struggle. Most of the times, as Dr. Poja said, when I make my incisions with the good quality keratomes, I don't even have to seal my main ports. I can just seal the side ports and get away. And here, you're actually struggling. You're doing a quality surgery. You're doing a trifocal lens, maybe a toric, and then you don't want to compromise on your incisions. So this is what can sometimes happen. You can see this inner lip over here, and this is what I don't like sometimes about my femto incisions. And so there can be also a lot of contraindications where, if you have a pannus, you have corneal opacities, you have a radial keratotomy patient, you have peripheral corneal thinning, compromised endothelium. I remember reading a study, where they did some studies on the endothelium with femto assisted versus keratome, and they were suggesting that, don't use high energies on, doing the corneal incisions. Now, this is again another study which was published where, they've compared a keratome incision versus the femto incision at 1 month. And you can see that the femto incision somehow, although it is nicely triplanar, has not, still healed from the internal. The anatomical healing is not as great as the other one. So another situation where I've done RK, I've done a femto assisted RK also. My choice of surgery is a femto assisted. Just see that the incisions are making good progress. So I actually enjoy making them. Just see the incisions seamlessly. Watch here. I'm not even stabilizing my
Gaurav, you
gloves.
need to kill the volume.
One minute.
Gaurav, you need to kill the
Yeah.
volume. We can't hear you.
Can you? Okay. Just watch that. I don't even need to stabilize my globe with a counter pressure. I'll just make the main port incision very precisely. There is no stabilization of the globe, and the blades are fantastic. So it can actually give you an excellent. And just watch the end of the surgery. As I finish the surgery, I do a trypan blue Seedles test to watch my main ports. Now, arc incisions, you can understand, are difficult to make, difficult to handle, and then difficult to close. But as you can see here, these incisions feel seamlessly, and I really enjoy making these incisions with my keratomes. So another situation where we are using femto assisted surgery, but using the money blades, which I prefer to use today. And we can reuse them a few times. It's not probably recommended, but for sakes of compromising on the cost that we incur, we do plasma sterilize a couple of times. But I won't recommend it. But off label, I can say that they still continue to work beautifully after a couple of autoclaves as well. And you can do a good surgery there. You can again see that here with minimal pressure, it literally kind of, I have to actually hold my hand back because it goes in sometimes so fast that you have to be a little careful. Another situation where we are doing a black cataract, and probably the same thing. So let me go on. I think Kamal is waiting for his dinner. So to summarize, a good steel disposable keratome, I think, works much better in my hands than the femtosecond laser or even the diamond knives for predictable, safe incisions, complication free. Choosing the right keratome is so critical to a good surgery and avoiding complications. And with that, I think